So in this presentation we're going to review the Bradycardia's algorithm from ACLS, which will include sinus bradycardia as well as first, both types of second degree and third degree AV block. Here's the ACLS algorithm, all in one page. Fairly simple compared to the tachycardia algorithm. You'll notice that first comment is they want you to assess the appropriateness for the clinical condition, and this algorithm is probably only going to apply to patients with a heart rate of less than 50. Some of that it would be a normal variant in a person, but particularly a well-conditioned person, maybe a person on a beta blocker that keeps their heart rate fairly low, although less than 50 is usually a problem. Something in the 50s or low 60s in a person with a healthy ventricle, healthy heart, is probably not that big a deal. And the next box on the algorithm talks about identifying and treating the underlying cause, and this is particularly important with sinus bradycardia because most of those have a treatable cause, usually parasympathetic tone, and we can treat that. 12 lead EKG if available, but don't delay therapy. The point there being that to differentiate these bradycardias or to determine your treatment, because really the treatment is based on the rate and the patient's hemodynamics more than it is the particular degree of block. But the 12 lead is not particularly helpful with these, whereas in the tachycardias it may be a little more helpful. In the bradycardias, you can see that just fine in lead 2. Next thing that they're looking at is discussion about how symptomatic is this patient. Are they truly hypotensive? Loss of a radial pulse or a very low measured blood pressure? Are they acutely altered? Do they have signs of shock? Is this chest discomfort due to an ischemia, which again the 12 lead would be necessary to determine that particularly? Are they in acute heart failure? This is exactly the same pink box, box number 3. It's exactly the same box as we use in the tachycardia algorithm. And we used to refer to this as stable or unstable, and now it's probably more helpful to think of it in terms of, are they truly symptomatic, severely symptomatic, or are these mild symptoms where we can be relatively conservative? And then we move down to the treatment box, box number 5, the blue box. Atropine, atropine, atropine is going to be the first choice. Now, as we talk further about this, we'll of course bring out that atropine is unlikely to be effective in high degree AV block. So a second degree type 2 or a third degree, it's unlikely to be effective, but atropine remains a consideration and probably the first line treatment in most of these. Then the second point I want to bring out is that in previous algorithms, and for those of you that are initial students, this may not have much meaning, but for practicing paramedics, in previous algorithms from 2005 and prior, we've had transcutaneous pacing or dopamine and epinephrine, but really pacing was listed as a priority, as a thing you should try next. So in your cookbook, as you work down the list, it was atropine, then pacing, then if pacing didn't work or wasn't available or going to be delayed, then you tried an infusion of dope or epi. And now in the 2010 guidelines, they've moved the dope and epi drips up to equal status with transcutaneous pacing. So it's important when you read this algorithm that you don't read that that they're listed in order and make the false assumption that pacing is better. ACLS is telling us that pacing is equivalent to a dope or an epi infusion. So let's quickly talk about sinus bradycardia. Here's an example, a nice clip that I grabbed from the web, talking about heart rate, rhythm, P wave, PR interval, and QRS, a very nice process to identify and differentiate these rhythms. But again, the key with ACLS is that it's about the rate. And whereas rate affects cardiac output, it's about the rate and their hemodynamics and how symptomatic they are, more than it is an identification of the precise rhythm. However, sinus bradycardia, very clearly, if it is very hypotensive, first line treatment is going to be atropine, and atropine will be effective in a fair number of these cases. So a 0.5 milligram bolus, and then in about 3 minutes, if you haven't seen any change, Repeat that. If you feel like the patient's very symptomatic, you might get some medical control to override that 0.5 at a time and maybe give a full milligram. And then the max dose is 3 milligrams. Once you've given 3 milligrams of atropine, their parasympathetic system is blocked, and you're not going to get any real further activity from that. So I'm going to move this rhythm to the back where we can see the full algorithm again. Identify and treat the underlying cause. Primary concern in sinus bradycardia is determining that underlying cause, but parasympathetic tone, excess vagal tone, is one of the most common causes of that, and we can eliminate that or rule that out or fix that with the use of parasympathetic antagonists, and our favorite one, and about only one we have, is atropine. So the usual stuff: airway, breathing, oxygen, full set of vitals including a 12 lead, and then move quickly down to atropine. And in the very symptomatic patient, it would be appropriate to go ahead and place your pacing pads and then make preparation to hang a dope or an epi drip. Get your epi out and your syringes and such to draw it up, or get your dopamine premix out and be ready to do that. And as we move into other potential rhythms that cause bradycardias, acute onset of a heart block would be one of those. And typically here we're talking about higher degree blocks, a second degree type 2 or a third degree. And you'll notice that there are several possible causes, but cardiac ischemia or infarction is one of them. It's certainly, I don't think, the most common from what I've understood, but it is something for us to check on and be aware of. So the fact that you're seeing a bradycardia, which is causing symptoms, which has caused you to get into this algorithm, don't forget that these patients may have some ischemia going on, and we may be able to fix the heart block and the bradycardia if we can address the ischemia. Here we have a very obvious first-degree heart block, a fairly dramatic, fairly prolonged first-degree heart block. And again, remember that it is the PR interval, not the PR segment. So the PR interval is from the start of the P wave until the start of the QRS. That's the PR interval. And if that is longer or wider than one big box, 5 small boxes, then that is, by definition, a first-degree block. These are typically not something for us to be very concerned about. It may or may not progress to a higher degree block. Folks may walk around with this all the time. But we should be aware that there is some disease or defect in the AV node that's causing the impulses to slow dramatically as they go through the AV node. They're supposed to slow a little bit, but they're not supposed to slow this much. So first-degree block, fairly benign. Definition is greater than 0.2 seconds, which is 5 of the small 0.04 wide boxes, so greater than one big box. And the PR interval starts at the start of the P and ends at the start of the QRS. Here we have a second-degree type 1 or Winky Bach. The hallmark of this, the obvious way to pick this is to look at your PR interval. In first-degree block, the PR interval is simply just too long, but it's constant. In second-degree type 2, the PR interval is constant. It may or may not be too long, but it's the same amount no matter what. But in Winky Bach or Mobitz 1, second-degree type 1, your PR interval gets longer and longer and longer, and then a complex is dropped. So if you look at PR intervals as part of your assessment and your analysis of the EKG, this is the key for second-degree type 1. Second-degree type 1 is a little more concerning than first-degree, but this is not a high-degree block, something that we're very concerned about progressing further. Again, it gives us information that something's not right in the AV node. Conduction is being slowed and slowed and slowed, and finally it's slowed so much that the QRS is dropped. So it's just kind of a warning sign. Maybe cardiac ischemia, maybe excess vagal tone. If these patients are very symptomatic, then atropine is what we're supposed to try first, and there's a legitimate chance that it's going to make a difference. So here's a second degree type 2, a more concerning block, a high degree AV block. And you can see with the 6-second strip that we have here that the ventricular rate is in the upper 40s or very low 50s, based on which snapshot you take. And as we know, rates below 50 in healthy hearts are concerning, and in unhealthy hearts, unhealthy ventricles, ventricles that have had infarctions before and their stroke volume is impaired, even rates in the 50s and low 60s, maybe even the 70s can be an issue. So the rate itself is the first thing that would concern us in this case. And then the wide conduction, the wide QRS shows that there is some delayed conduction. And so then you start looking at P's to QRS's. And in this case, the PR interval is going to be constant when there is one. That's the same as that, the same as that. But there is no QRS there, or there, or there. This is a variable ratio of conduction. So the AV node is blocking every other P wave or every third P wave, and sometimes two P waves in a row. So this should be of concern. Atropine may be helpful in this case, or it may not. I wouldn't rely on it totally, but it would need to try it first based on ACLS guidance. But this patient would immediately get pacer pads applied, and I would immediately dig out the dopamine or epi and start preparing the equipment to mix that drip or to set up that drip, as well as preparing myself to deliver. This is a high degree block in a concerning situation. The ventricular rate is the key. If the patient's ventricular rate cannot be improved by atropine or oxygen therapy or whatever else we can try, then we're going to have to make it better. We're going to have to pace it, or we're going to have to use beta-1 agents, positive chronotropes like dope or epi, to get that rate up. And then here we have another very concerning rhythm, a high degree block, third degree AV block. And of course the characteristics of that are that the P waves march through at one rate, the QRSs march through at another rate. Those two rates are not related. PR intervals are completely variable because there aren't really any PR intervals to speak of. There isn't a P associated with a QRS. And so the real key here is this ventricular rate. And when I first see a rhythm like this, I see the wide QRS, I'm very concerned. I see a very slow rate. Now I'm extremely concerned that this patient's cardiac output isn't even going to keep up. Now this is not a 6-second strip. 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So this here, circled in the blue, would be half of a 6-second strip, a 3-second strip. And so I'm going to multiply the number of complexes I see in there by 20 instead of by 10, and I only see 2 and almost a third. So I'm thinking that this patient's rate is in the 40s, probably can't keep their cardiac output up, and I'm going to, again, try some atropine, but I'm not going to rely on it because I just don't believe that this is caused from excess parasympathetic tone. This is significant disease or defect or possibly severe ischemia in the AV node, and so this is not a vagal problem. It's not a parasympathetic problem. This is a conduction problem, and the fix for this patient is going to be probably long-term an implanted pacemaker. In the hospital, they may be able to do a temporary pacemaker, and we may have to use our external or our transcutaneous pacer in the field. So as soon as I see this, I'm putting pads on, and again, getting out the dope and epi and preparing those therapies, as well as preparing myself to deliver those therapies, and with the pacer pads on. And I'm going to try some atropine, but I'm not going to rely on it. And if this patient is tremendously symptomatic, if this patient really fits in this pink box, has 2 or 3 of those, then I'm going to move rapidly to pacing, and also rapidly to the phone, rapidly to get some expert consultation. Yes, it is true that external pacing is painful, but I think in our practice we're going to find that most of the patients that fall into this part of the algorithm and need us to pace them are going to have severely altered mental status. And it's not that it won't hurt, but it's that we need to get their cardiac output fixed, and then if they don't need that pacer any longer, or if they're going to need it for a longer term, then we can consider some sedation or some analgesia. Most of these folks are going to be too hypotensive to do anything in terms of sedation or analgesia in the first place. So if fentanyl or Versed is only going to make matters worse. So I wouldn't be afraid to pace this person, but I also think that now that ACLS has made pacing and dope and epi all equivalent therapies, in that patient who's not very altered, almost unresponsive, then I think the infusions do have a place. So pacing's probably what they need, or they're going to need a significant infusion of a beta agent, a beta 1, for a positive chronotropic effect, and our ability to get dopamine hanging quickly, get epinephrine hanging and going quickly, without a bunch of complicated calculations or messing with a pump that we're not particularly familiar with on a daily basis. It's important that we be able to get those infusions hanging, and so we've addressed that in a different presentation. But third degree AV block, very concerning because of the rate, which affects the cardiac output. The way we need to help this patient is to fix the rate. So in brief summary, the key for this algorithm is for us to determine how symptomatic are these patients, and to not write off atropine because we're afraid that it won't work. In many cases it will work, but in some it won't. Identify those that are very scary to us, those high degree blocks with a slow rate, probably a wide complex, and prepare ourselves and prepare our dope and epi drips as well as our pacers. So that's bradycardia in a rather quick overview.